Good afternoon, ladies and gentlemen. Let us move on to the post-lunch session of the second day of 3D conference. We have two topics for discussion today in this session 14. The first one is, can DPP4 inhibitors be a good partner to metformin? It's a million-dollar question to be answered, but then to discuss on that, I believe there's a change in the program that Dr. A.K. Singh is not available now, and Dr. M.C. Deepak will be speaking on the topic to discuss on the finding the ideal partner for metformin. Can DPP4 fill the gap to be a good partner for metformin? There's a slight change in the topic, right? Finding the best partner to metformin.
Good afternoon. Thank you, Dr. GVK, for this opportunity. I lost my sleep this morning anyways. I thought I'd sleep till 9, but I was woken up at 7. Okay. Thank you, chairpersons, for introducing the topic. And the topic assigned to me is DPP4 the best partner to metformin? I thought I'll divide the topic into two small subdivisions, DPP4 versus sulfonylureas versus SGLT2 inhibitors. If you look at across the globe, a major number of patients are on sulfonylureas. The next comes the DPP4 inhibitors. So we have the maximum number of patients. We have the maximum number of patients who are on DPP4 inhibitors and metformin. Insulin and SGLT2 come later. Sulfonylureas are wonderful drugs. We've been using them over the years. They're very useful. They stood the test of time. They get the blood glucose very easily down. We have a vast experience with this drug, but however, the risk of hypoglycemia, the antecedent weight gain, and the issues with the glucose variability and durability because of the declining beta cell function make it as probably not the best partner, but nevertheless, we'll have to wait for the Carolina trial. The top-line results say that they're pretty safe. The 3-point MACE is equivocal to that of glimepiride is equal to that of linagliptin, so we'll have to wait and watch. All the meta-analysis show that there is at least about 2 kilograms of weight gain when you use the sulfonylureas. So the DPP4 inhibitors come handy as good drugs, low risk of hypoglycemia, weight neutral, cardiovascular safe, safety profile similar to that of a placebo, very few drug interactions, no timing or dosage issues, very good compliance. And then it comes as with metformin, a single pill, so drug compliance is not a major issue. So let's actually fight it out between DPP4 inhibitors and SGLT2 inhibitors. The 4 important points that I'll be looking at: the efficacy, the weight reduction, the CV protection, and what the guidelines have to say. In terms of efficacy, if you look here, at the end of 12 weeks, between 12 and 26 weeks, if you will note that there is no difference in the HbA1c lowering. But if you were to increase the follow-up beyond 52 weeks, SGLT2 inhibitors have a small advantage of minus 0.11 reduction in the HbA1c, 0.11. So if you increase the duration of therapy, then you have a slight advantage. But then nevertheless, this 0.11% of better HbA1c reduction with the SGLT2 inhibitor does not warrant the use of this as the first drug after metformin. When we look at comparisons between these two groups of drugs, we need to look at the dose of SGLT2 use, the type of gliptin, the baseline HbA1c, the renal function, and other considerations like age and race. So let's look at a comparative study. If you were to compare CANA versus CETA, you find that there is no difference. EMPA 0.1%, which is not statistically different. And similarly here, you have that CETA was probably more superior. However, these are very small RCTs. So what I'm trying to say, there are no better drugs in terms of blood glucose lowering. Both are equipoise. Now, this is data from the Canadian primary care physicians. I put this study here because most of the audience here consists of primary care physicians, and what they found there was that a large number of their patients were having an A1C between 7 and 8.5. So that is what we even see in our practice. When we want to add the next drug, a large number of our patients will be between 7 and 8.5. Now let's look at this data here, which says that if the A1C was less than 8.5, linagliptin with metformin seemed to work better. But if the A1C was greater than 8.5, then the SGLT2 inhibitors seem to act better. So if you have a higher A1C, then the SGLT2 would be a better partner. But when you have a lower HbA1c, which is between 7 and 8.5, which I presume would be the crux of what many of the primary care physicians would see, then I think gliptin is a no-nonsense, very simple drug, no ifs, no buts, no checks, no pulls. Right. Now let's go to the next point, looking at the estimated GFR. Now what happens is, if the eGFR is falling below 60, which is quite common in most of our patients, we will find that the glucose efficacy, glucose lowering efficacy of this particular drug is down by 50%. So therefore, what happens is that if you have a better A1C, then the glucose lowering effect is probably much more better with this particular molecule, whereas with the gliptins, whether it is Sita or Linag, you have a glucose lowering effect which is quite robust, and you don't have to worry about the dosage reduction with linagliptin. With sitagliptin, yes, of course, we do calculate the eGFR, and thereby we reduce the dosage of the drug. Whatever be the age of the patients, the SGLT2 and the DPP4 seem to be quite effective, and also whatever be the degree of beta cell failure, looking at the HOMA-IR, the HOMA-beta, whatever be the HOMA-beta, the SGLT2 inhibitors and the DPP4 inhibitors seem to be equally effective, and even whatever be the pro-insulin is to insulin ratio rate. In the elderly individuals, the gliptins across the class seem to be pretty effective. There is some reduction in the efficacy with the SGLT2 inhibitors in the elderly, probably because of there is some reduction in the eGFR. So in the very elderly, the efficacy comes down a little bit. And of course, we also have to remember about the side effects with the SGLT2 inhibitors, especially that is volume depletion and electrolyte imbalances. So whether it is the Asian or the non-Asian cohorts, you had an equivocal reduction in glycemia. So that was a very heartening thing to note. The same thing is seen for the SGLT2 inhibitors. So what about the efficacy of the drug? SGLT2 is only half as effective when the eGFR is lowered. We do understand that. And the SGLT2 are only 1/3 as effective when the HbA1c is less than 8.5. So if you are looking at a drug in order to primarily reduce the glucose, then the DPP4 inhibitors come as a very handy choice without much ado. Now, so how do you choose the right patient? So far I've been talking to you about a patient who's not had any complication. So let's look at these subset of patients. Weight, blood pressure, there seems to be a small weight advantage with the SGLT2 inhibitor. 3 kgs to 4 kg is what we actually get to see, but DPP4 inhibitors are weight neutral. However, SGLT2 inhibitors are not promoted as weight losing agents. Both of them reduce the blood pressure slightly. Of course, they are not promoted as antihypertensive agents. So let's look at the cardiovascular benefit. We all know that the empagliflozin seemed to look like a game changer to us, and the credence seems to look like a game changer in terms of renal protection. Now, but just let's dissect the whole set of these EMPA-REG trial, and let's see what the findings have been. Now, if the A1C in the EMPA-REG subset, those patients who had an HbA1c greater than 8.5, the hazards ratio was 1.14. But if the A1C was less than 8.5, the hazards ratio was 0.76. So is it true that empagliflozin is really cardioprotective in patients with a higher HbA1c value? The answer is inconclusive. Let's go to the next thing, renal function. Even the Credence trial, which was released 3 days ago, about a week ago, said the same thing. The maximum benefit would be seen only when the EGFR, renoprotection, is when the EGFR is between 60 and 90. And similarly, the blood glucose lowering in patients, most of us see our patients in the hyperfiltration stage. When I say most of us, I mean primary care physicians would see patients in the hyperfiltration stage, where the EGFR is greater than 90, there the hazards ratio was 1.1. So the question that I would like to ask is, does it really look that empagliflozin was cardioprotective in patients with good renal function? We do not have answers. We'll probably have to wait for the EMPA-Kidney trial and the DAPA trial to get more answers. In the younger population, again, less than 65 years, the hazards ratio was 1.04, whereas greater than 65 years, the hazard ratio was 0.71. So are the results skewed? I wouldn't go into an argumentative mode, but what I'm trying to tell you, in these three subsect of populations, probably the benefits are not as much as they have been highlighted. So the gliptins are not a bad choice. Definitely, there are a lot of benefits by using the gliptins or the DPP4 inhibitors for a primary care physician who's overburdened with more than about 100 patients to see in a day. Right. So therefore, what sort of benefit did we get with the SGLT2 inhibitors? Very old? Well, in the very old, you had an improvement in the heart failure, but at the same point, was there an improvement in the efficacy of glucose lowering? In patients with mild renal dysfunction, what happens to the efficacy? As the EGFR falls less than 60, the blood glucose lowering comes down by about 50%. And if the HbA1c was less than 8.5, again there the efficacy was not as robust as seen with the DPP4 inhibitor. In between, we had a small period where the cardiologist was extremely unhappy to see a DPP4 prescription because of all this fear about, cardiac failure, the SDF1, and whatever you could call any hypothesis. But today, it's heartening to note that there is no excess heart failure risk when seen in the TCOS trial and as well as the Carmelina trial. So I think in a patient who's had stable heart failure out of the ICU, you still you have a role for the DPP4 inhibitors. The linagliptin in the Marlina renal outcomes trial, over and above an ACE and ARB, was able to reduce the microalbuminuria, which is again very heartening for us to note. The reason for this is that what we've less spoken about in the conferences is about I heard this yesterday, but many people don't generally talk about autophagy. The DPP4 inhibitors promote autophagy. As a result of this, there is inhibition of podocyte damage, and the increased GLP-1 receptor expression in the kidney probably protects the kidney from fibrosis. And there's a lot of markers like TGF-beta, all these which are being assayed. So it's quite exciting that these gliptins are definitely helpful. So what does the guideline say? If you have a patient who has already had heart failure or chronic kidney disease, then there is a place for starting SGLT2 inhibitor immediately. If you have a patient who's already had atherosclerotic cardiovascular disease, then there is a place for starting a GLP-1 receptor agonist. So in patients where hypoglycemia, weight gain, which is the primary concern of all primary care physicians who have assembled here, then I think the DPP4 inhibitors make an extremely good choice. I do not stand here telling you that this drug should not be used in patients who have had stable heart failure. If a patient has had stable heart failure and he's out of the ICU, then I would use an SGLT2 inhibitor. If the patient has had an atherosclerotic vascular disease and the patient can afford it, I would go for a GLP-1 receptor agonist, even though it is by needle. But in the major chunk of patients that a primary care physician sees, I think the DPP4 inhibitor is extremely good choice with metformin, because there is an extreme synergy between these two molecules, and 7 out of the 8 in the ominous octet are taken care of. So If you want to relax after a prescription, what you want to give next after metformin, in most of our patients who are generally don't come back regularly on time for their consultations, you don't want to worry about genital infections, you don't want to worry about repeated EGFR estimations, you don't want to worry about euglycemic ketoacidosis, you don't want to worry about volume depletion, more so if the patient is on a diuretic, or the fractures and the weight gain and the increased risk of congestive cardiac failure which you see with the glitazones. And you don't want to have this problem, every guy coming and saying, sir, I puked today after taking a shot of the weekly GLP receptor agonist. For a simple primary care physician overburdened with over 100 patients, I think the DPP IV inhibitors would make an extremely beautiful choice. Thank you so much for a very patient hearing.